Hi, everybody. Welcome. Happy Monday. Welcome to our next CCRN review webinar. These are just little webinars that we do, quick 30 minutes, go through some practice questions, interact with each other a little bit, learn something new, hopefully. Just another way for you to study for your CCRN. Just to introduce myself really quickly, in case it's your first time here, my name is Rebecca. I am the CCRN instructor with Archer Review. A few months ago, we just launched a whole course with on-demand video lectures, over 13 hours worth of video lecture material. So we are super excited about that. It is proving to be pretty successful for nurses that are pursuing their CCRN using our on-demand lectures as well as our QBank, which is super exciting. I love to get the information that people are passing their CCRN using our materials. Um, so yeah, I've been in the ICU ever since I graduated nursing school, started as a new grad, cardiac surgery, cardiac medical ICUs, general ICUs, travel nurse for a bit. So I've been all over, and just love ICU nursing and love talking about it. And really my main goal is to make concepts that seem like they would be too complex to understand, break them down into simpler pieces so that everyone can feel more confident at the bedside. That is the goal. So excited to have everyone here. Who is here today? Let me know your name. You can throw it into the webinar chat here. Your name, where you're from, where you're at in your CCRN preparation. Do you have a test scheduled, or are you more just starting to think about getting your CCRN? Where is everyone at in their CCRN journey? And then we will talk a little bit more about CCRN. Let's see. Excuse me. Hi, everyone. Perfect. Carter, you're testing June 18th. Awesome. Cindy's taking your test on July 1st. Great. So we've got a couple people who already have their tests scheduled. Way to go. That's definitely step number one. So that's awesome. How are we feeling? How's everyone feeling as they prepare for their CCRN? Has this been kind of a fun process? Has it been arduous and painful? How do we how do we feel about our preparation? For me, I had a lot of mixed feelings. Sometimes it was fun. I felt like I was learning so much by preparing for the CCRN, like so much. There were so many things that I just thought, oh my gosh, I can't believe I didn't look into this earlier and learn this earlier. And I've been a nurse now for a few years. And that part was fun. I just felt like, wow, I'm really actually learning something. Regardless of what happens with this exam, I'm becoming better. And that's exciting. And then other things were really difficult to understand. So there's still concepts that I remember going over for the CCRN that I still don't fully understand. Um, and that's the lifelong process of learning, right? That's just what we signed up for as nurses is to learn over and over and over again, and one day it'll stick. Okay, yeah, I like that. Nice seeing real application in practice, being able to connect things has helped. Reading a book tends to go in one ear and out the next. I am the exact same way. Even in nursing school, reading a book has never really worked for me. I had to get the information another way. So yeah, super exciting. That's why another reason we were really excited about this CCRN product is at least for me, that like visual and auditory learning worked a lot better for me. So more of the written material I don't do as great with, and I think a lot of people are in that boat. Really quickly, let's talk about the CCRN just in case you're here joining us on Facebook or YouTube and you don't know exactly what we're talking about. Plus, I've updated some numbers here. So, CCRN, this is our critical care nurse certification. So, this is a certification exam you can take and obtain once you have achieved a certain amount of experience in an ICU setting. There's a lot of different pathways to get that experience. 2-year options, 5-year options, kind of depending on how often you work. If you're a bedside ICU nurse working full time, usually in about a year, you have achieved that 1,750 hours and you're able to sit for this exam. When you sit for the exam, you will take 150 total questions. Only 125 will be counted. You need 83 correct to pass. And I'm forgetting now what that actually percentage-wise checks out to be. Is that 67%? Let's see. 66. Okay, you need a 66% to pass. Last year, 2024, there was a 72% pass rate, which I will point out if you've watched with these webinars before, you know that that number has gone down. I finally updated it for the 2024 number. We just got that information a few weeks ago. And in 2023, I want to say it was 81% pass rate. So we are seeing that go down. I think a lot more people are testing is probably part of it, which brings me to the motivations to be tested, to get to be certified. And that would be financially, hopefully your facility offers some reimbursement. If you're going back to school, I think that's the big reason we see a lot of influx in CCRN. Early test taking is that CRNA track or nurse practitioner track. Being certified is really, really important for that. And then, like what I talked about at the beginning, just increasing your confidence at the bedside by learning new material, and kind of closing the loop on things that we see in practice, but we don't might not totally understand. The CCRN is really good about nailing down those concepts that we see all the time. Feels very applicable. So there's lots of reasons out there to become certified. Like I talked about, we've got an on-demand video lecture course all broken down into bite-sized pieces. So each little video is about 10 to 15 minutes long. We just have many of them, so it makes up over 13 hours of content. But you can really customize how you want to learn the material, which is really exciting. And like I said, people are now that it's been out for a few months, we can we can get that information that people have used the product and then pass their CCRN, which is very exciting. Okay, so let's go ahead and get started. Like I said last week, today we're going to be talking about just general practice questions and concepts. This is a complete catch-all for anything that you could see on the CCRN. We're just going to go through practice questions together. Sometimes I think it is nice when you are studying, if you go, like, let's say you're spending a day talking about cardiovascular concepts, it's great to take cardiovascular questions right after you learn that material, or even before you sit down and try to study that material, so you can see where you're at, kind of assess your level of understanding. But it's also really important to take practice exams that are more general. You have no idea what's coming. That way you can really simulate that testing experience. So that's kind of what we're doing today. Not really simulating the testing experience, but we just don't know exactly what concepts we're going to touch on, and that can be helpful to do as well when you're studying. So let's go ahead and get started here. Thanks for the interaction, everyone. I appreciate it. Go ahead and throw your answers to these questions in the chat. It really helps me to be able to see what we're thinking with these questions, so that I know more what to talk about. If we get a lot of answer choices that are the wrong answer choice, I can spend more time talking about why the right answer is the right answer. So it'll make this more effective. So go ahead and throw your answers in the chat if you can. All right, let's start here with this first one. An intubated elderly patient becomes agitated, confused, and pulls at lines. Vitals are stable. CAM ICU is positive for delirium. What is the best immediate intervention? I'll have you read through those answer choices. Go ahead and throw them in the chat, and then we'll talk about it. Okay, seeing a couple come in. I'll wait just a little bit longer. Yeah, okay, a couple different answers. So that's good. Um, in a way, like I said, that's what I like to see, because then I know that we've got something to talk about if we see different answers, right? So for this question, it looks like people have narrowed it down between A and C. Those were the most popular answers that I saw come in, which is great. Those are probably the two top answers, I would say, for what we're seeing here. So the correct answer here is C. Reorient, reduce stimuli, ensure sleep, and vision aids. Now, I know that you're thinking, for those that said A, you're thinking in practice, if we had an intubated patient and they became agitated and confused and were pulling at things, we would apply soft wrist restraints. We absolutely would. Um, for your CCRN, this is one of those concepts that, 'cause I feel like do you remember studying for your NCLEX and there were so many things that they were like, you can't really think about the real world here. You're thinking of that perfect hospital up in the clouds that doesn't really exist because that's what and how the NCLEX wants you to think. The CCRN is better about that. They do want you to think about the real world, but when it comes to some of these professional ethics questions, this is probably a multi-system slash professional ethics question with this ICU delirium happening. They are going to want us to think through what is like the right answer, right? Like the what should we do? Technically, when it talks about what's our best immediate intervention, we should try non-pharmacological and non-restraint methods first. This might be getting a sitter with the patient. This with the fact that they're intubated is where this gets a little bit more convoluted and confusing because again in practice we would restrain an intubated patient if they're starting to pull at lines and they have a neurostatus compatible with being awake enough to pull at their ET tube. But for immediate intervention, our first thing we're going to do is try to reorient that patient and say, you know, Miss A, you're intubated. Try not to pull at your lines, and then we'll probably end up applying those restraints. With these more social questions like this, choose that non-restraint answer first, unless it were to say you've attempted reorienting the patient, you've attempted reducing stimulation, what's your next intervention? Then it would be apply soft wrist restraints. It doesn't mean that we're never restraining the patient on the CCRN. It just means if they say nothing else has been done yet, we're going to try those first. Which I know, again, for safety, we're thinking, no, they're intubated. We need to get them restrained. I totally understand. But for these types of questions, when they tell us nothing else has been done yet, they want to see that first. Does that make sense? I know that those are extremely frustrating questions. Oh gosh, I had to pick one that, even angers me right to start off. But okay, let's keep on moving. A post-op liver transplant patient is 6 hours out from ICU admission. Vitals are heart rate of 110, blood pressure 102/60, temp is 99.2. GCS drops from 14 to 10, and there's new asterixis noted. Lactate is 3.8, ammonia is 112, and glucose is 54. They are ventilated on an SIMV setting or mode with SpO2 of 95%. What is the priority intervention? Lots of information for this one. Good job, Adriana and Carter. Awesome. Yeah, good job. Perfect. This question gave you so much information, and it's really seeing if you can kind of filter through all of these lab values that some of them really don't look great. Some of them look worse than others, and really see what is the priority to do about all of this information. That you've been given. And y'all are exactly right. The answer here is A. We're going to fix the hypoglycemia before we worry about any of these other changes that we're seeing, because the hypoglycemia could be causing, for instance, a lot of these neuro changes that we're seeing. It's the easiest thing to fix first. We probably still need to do something about this ammonia level, but the first thing we're going to do is fix the hypoglycemia. So great job. That was really just making sure that you could, again, take a wealth of information, assess what is the true priority and what can be fixed the quickest. That would help your patient status the most. So excellent job. That one's a less infuriating question than the last one. Okay, let's take a look at this one. A patient post hip replacement is 3 days post-op and suddenly develops a respiratory rate of 38, a heart rate of 142, blood pressure 94 over 58, and SpO2 of 88%. ECG is showing sinus tachycardia. ABG is showing a pH of 7.46, PaCO2 is 29, and PaO2 is 58. CVP is 12, lungs are clear, and there's no chest pain, and her lactate is 4.5. What should the nurse expect next? Again, lots of information. Nice. Everyone's doing great. What do we think this person is experiencing? What condition? Okay, a few different answers. We've got some saying A, CT of our pulmonary system and prep for some thrombolytics. Some are saying B, we maybe should start fluids and trend lactate. We've got fatty embolus versus pulmonary embolism, leaving it a little bit more broad. Yeah, okay, so we've narrowed this down to A and B. This question is assuming that a pulmonary embolism is occurring, and there's a few things that tell us um, that it's not B with that start fluid bolus and trend lactate. And one of the things that kind of rules B out is our CVP is 12. So with that, we don't seem to have too much of a fluid deficit happening that this person would need fluids for. Um, why do we think that CVP is elevated? What does that kind of tell us is going on? If we're thinking this is pulmonary embolism, what other condition is going on if our CVP is elevated? Still very related to the pulmonary embolism. Yeah, exactly. We've got a little bit of right heart strain. Elevated pressures can't fill into the lungs. Yeah, so the right heart is struggling to empty and eject into the pulmonary artery because there's a blockage there. So yes, we've got a little bit of respiratory alkalosis from our tachypnea, a respiratory rate of 38. Our heart rate's accelerated. We're in some sort of stress there. Tachycardic, lactate is up. Um, we don't have chest pain yet, and we don't have severe hemodynamic instability. So we would probably consider this a submassive to massive pulmonary embolism. With this CVP being elevated, that would tell us there is that right heart strain, which puts it into that submassive category of pulmonary embolism. When we see more severe, and this might even fit the criteria, so I don't want to speak too surely, but when we see that hemodynamic instability and our blood pressure starts to drop, then we're concerned for that massive pulmonary embolism. Now, we saw a couple answers for fatty embolism or a blood clot here. If we're going to prep for thrombolytics, we're probably assuming that this is more of a DVT becoming a pulmonary embolism problem. That will break that up. If we've got a fatty embolism, unfortunately, those are so microscopic, we might not use anticoagulation in the same way for a fat embolism, but it kind of depends on the patient and seeing what that CT scan looks like because they could have a combination of both happening. Um, so yes, either way, great job, everyone. Couple different answers there, like I said, and that's totally, totally fine. What's nice is it seems like we're narrowing it down to what should be the two that we um, are kind of wrestling between. Okay, let's move to the next one. Septic patient receiving antibiotics shows platelets 45, INR is 2.3, D-dimer is elevated, and fibrinogen is 105. There's evidence of new GI bleeding. Blood pressure is 90 over 60 on pressors. Urine output is 5 milliliters an hour, and the patient's confused. What's the first intervention? Somebody asked CVP normal value for that last one. We'd say anywhere from 2 to 8, but it can fluctuate depending on what's going on with the patient. If they just came out of post-op cardiac surgery, we want it to be higher, just for instance. Good job, Adriana and Carter. Cindy, I see where you're coming from. Okay. What condition, before I give the answer, what condition do we think this patient is in? We're thinking DIC, right? Disseminated intravascular coagulation. We have a septic patient. Sepsis is one of the main causes for DIC. And we've got all of these lab values telling us that clotting factors are being used up. We do not have enough clotting factors running around to keep us from bleeding. So that's why we're having bleeding. DIC is characterized by both clotting, usually microvascular clotting, small little clots. And then with all that clotting that happens, we use up all of those clotting factors and now we'll start bleeding. We can't clot where we need to clot. And this is a very standard lab profile for disseminated intravascular coagulation. So what we're going to do is we need to give some clotting factors back to the patient. Now, administer fresh frozen plasma and platelets. Platelets, these are low. This platelet count is low. We don't always administer platelets for 45,000. A lot of times we'll wait till they're a little bit lower. But when we know that we've got new GI bleed happening, we're more prompted to replace platelets even before we hit that really low platelet number, just because we've got an active bleed occurring. Fresh frozen plasma. What one of our labs here is the fresh frozen plasma going to help? When we recheck labs, what number should get better after FFP? Anyone know? This is matching blood products to the actual lab value that it will help with. So FFP has the clotting factors in it that will help reduce our INR. When we have that prolonged INR showing our bleeding times are prolonged, we don't have enough clotting factors. The clotting factors that relate to that clotting cascade that INR is assessing are in FFP. Now, what blood product could we give to help increase our fibrinogen? Because this blood product has fibrinogen in it. It's not one of the answer choices. This is just another question. Yeah, perfect. Cryo, right? So this could have also said cryo. So that's a really helpful thing to feel pretty confident about. When you look at all of these labs, you're thinking to yourself, well, what would I give to fix each of these? Platelets are obvious. You'll give platelets for low platelets. INR is that FFP. D-dimer, we don't give a blood product for. And then fibrinogen is cryo. Perfect. And then obviously hemoglobin, we give red blood cells, that sort of thing. It's really, really helpful to know which blood product treats what. And it's really the ones that aren't obvious is the FFP and the cryo. So excellent job, everyone. Okay, we aren't going to transfuse RBCs for blood loss when we aren't given a hemoglobin. That's a good general rule for your CCRN, unless there's massive signs that this person's super hemodynamically unstable and it's because of bleeding, then you might would choose that blood answer, but you would need really significant evidence to transfuse red blood cells, not just evidence of GI bleeding. We had no, other than knowing their blood pressure is still a little bit soft on pressors, we don't have enough evidence to justify red blood cells. And norepinephrine's not going to fix our problem. They're already on pressors, increasing it. We've got to do some other things to try to stop this bleeding. Great job, everyone. Okay, let's do this one. A postpartum woman. We're not immune from L&D questions here on the CCRN, so keep that in mind. A postpartum woman with chorioamnionitis undergoes emergency section with an epidural. Post-op, she develops a heart rate of 52, low blood pressure at 72 over 40, respirations are 8, and SpO2 is 91%. Her arms are flaccid. She's unable to speak. What is the priority action? Couple different answers here. For this one, we're really thinking ABCs. Y'all are really doing an excellent job. Because even if you're not getting the question correct, you're thinking through it in good ways. Um, and you're getting the second to best answer choice, which is good. I said it last week. If you weren't here last week, you probably missed it. The questions that I did for the last Rapid 30 were really difficult. And I emphasize that I purposefully go through really difficult questions during these sessions. I try to do a little bit of a mix, but I want them to mostly be challenging so that we can really take advantage of this time of going through them together and hearing the explanation instead of just when you're working through a Q bank and reading rationale. So I don't want these to be discouraging, is the moral of the story. Just know that I am going through difficult questions to use this time as wisely as possible. Okay, the answer here is D. I saw answer choices for C and D most commonly, as well as A little bit. C and D are definitely your best choices. When it comes to the CCRN, we are rarely going to want to simply just assess something. We usually are going to try to do something, recognize what's going on, and try to do something. Can someone tell me what is going on here? What condition is this patient experiencing? It's kind of a unique name to it. Um, I'll give that just a couple seconds. Yeah, this patient's experiencing high spinal block. So when patients specifically are in our labor and delivery population that are getting epidurals very frequently, that epidural is supposed to, work at one area on the spinal cord and just affect what's below it. But that medication can sometimes spread and travel up the spinal cord. And that's what's happened here. This person's experiencing high spinal block, meaning that epidural medication is affecting an area of the spinal cord that it was never meant to, and that's the cervical area of the spinal cord. And that's why we're seeing that reduced respiratory rate. We're probably losing our sympathetic tone. So this is looking kind of like neurogenic shock because we don't have the sympathetic nervous system. Innervating our alpha and beta receptors, catecholamine release, all of that. That will cause that bradycardia and hypotension. And we've got this low respiratory rate. Our priority action is going to be intubation. With this respiratory rate, even though our SpO2 is not really low just yet, it's probably headed there. The best thing we can do for our ABCs when we kind of think through what's happening, oh, we've got anesthesia medicine going too high up on the spinal cord, we're probably going to lose control of we're in the process of losing our respiratory drive as we speak, or our ability to, it's not really the respiratory drive, but the ability to breathe, those muscles to innervate. Let's go ahead and intubate, mechanically ventilate this patient, cover that airway concern and our breathing concern. And then pretty quickly, we're going to be starting some norepinephrine. In the real world, again, would these be happening at the same time? Absolutely. We would see this. We'd call in for help, say, hey, we need to get the RSI kit in here, and can somebody grab me a norepi infusion? 100%. But when we think about what is the priority action, it's definitely intubation for this answer. So again, if you picked C, I totally see where you're coming from. This would just be one of those ones. Think about those ABCs and go back to that. Okay. Awesome job, everyone. Let's do one more. I know we're running out of time, but they're just fun. I don't know. I have such a good time doing these. Okay, a patient presents with glucose 1100, sodium 128, potassium 5.9, and creatinine 3.0. pH is 7.38. There's no evidence of ketones, and osmolality is 360. Mental status is altered. What is the first priority intervention? Great job, Cindy. Nice. Yeah, good job, everyone. Couple different answers. Let's go ahead and talk about it. So this is another one where you think, well, we're going to do lots of things, right? Which are frustrating questions. Well, first of all, what condition do we think this person is experiencing? I saw a couple, Adriana, you put that answer in there. Yeah, we've got HHS happening, right? So that hyperosmolar hyperglycemia. The most dangerous thing with our hyperosmolar hyperglycemia is going to be the fluid shift that's occurred and the dehydration. So when we think about, again, that first priority intervention, we want to start fluid. We're going to begin large volume fluid replacement with normal saline. And then we will initiate that insulin infusion to get the blood sugar down, treat the actual condition. It'll help with our mild hyperkalemia here. But the first thing we're going to do is begin large volume fluid replacement. So good job, everyone. That one can be tough because we think about how I was actually just having a one-on-one session with a nurse preparing for their CCRN, and we were talking about how you prioritize the answer choice when one is going to address the cause better and one is going to address the symptoms better. And you really do want to address the cause when you can. However, when we're in the ICU setting and we're managing these really critical patients, we likely do have to do some emergent symptom management. And then as we're working on addressing the cause, we sometimes can't always do, like, the answer won't allow us to do both. So in this one, we need to begin that large fluid volume replacement because that's what's going to make our patient the most sick right now in the moment. And then we can start that insulin infusion to address the cause. Um, oh, somebody went through this last year. I'm sorry. I know that's not fun just from having experience taking care of it. Okay, great job today, everyone. I know that some of these were kind of tricky questions. And again, I always choose more difficult ones. So don't beat yourself up if you felt like today was a tough one. Um, and we were all over the map on different concepts. I feel like everyone did a really good job. Being able to narrow it down to the top two answer choices is a really good step. And then you're just working through with each question, what's going to save my patient first? And then what's going to address the cause the best? And it obviously depends on what answer choices you're given. Let's go ahead and talk about our next webinar. We are going to do musculoskeletal and tegumentary. These are kind of funny body systems to me for CCRN because you just think, well, what are exactly like what conditions in those body systems do we really see in the ICU? What we're mainly going to talk about are things like compartment syndrome, rhabdomyolysis, burn injuries, that sort of thing. And those are the ones that are typically going to be there we go. Just sent that link out to the chat too. Um, what makes our patients the sickest when we're talking about those particular body systems. I call them little fringe body systems for the CCRN, but they are important and we do have to talk about them. So we'll go through those questions next week. All of these webinars are posted to YouTube after they're done. It'll be right up there immediately. So if you like this format of going through questions, definitely go to the Archer Review YouTube page. There's a CCRN playlist, and you can find our webinars that we've done there. Any questions I can answer? Was this helpful? Do we feel better or worse? How are we feeling? I know sometimes that these questions can just be tough. So I want to make sure we leave feeling encouraged. I really do think everyone's doing a great job from the interaction that I saw. Yeah, either scan the QR code or that link is in the chat. Okay, awesome, everyone. Thank you so much for being here. These are so fun. I look forward to seeing everyone next Wednesday. And again, if you have to miss it, you can check it out on YouTube after. Just a fun way to interact and get a different way of working through practice questions than when you're sitting on your computer and you feel like you just are so over it. So I'm really happy that you guys came by today, and we will see you next week.